So we're coming back now with endocrinology, and we're on case 3, and we're talking now about a 49-year-old man who was brought to the emergency department by his wife because he's not himself. He was very drowsy and not eating much for the last 4 days, and he was making urine every hour and was drinking water because he felt thirsty. His wife had not noticed any fever, chills, nausea, or vomiting. He was known to be hypertensive for about 10 years now, and takes hydrochlorothiazide. About 2 years ago, he was told that by his doctor that he had borderline diabetes mellitus and was started on a diet. No medications were prescribed at the time. So here, before I go to the rest of the history, borderline diabetes means now that this patient had diabetes. And it means that this patient had a fasting glucose of 126 2 times. So in the type 2 diabetic, remember the type 1 that we just talked about before, we had to use insulin right away. No doubt about it. But the type 2 diabetic is different. Initially, you could control this patient with diet. Later, you may need to use oral hypoglycemic agents. And maybe many years later, you may even have to use insulin. So about 80% of all type 2 diabetics, 10 years after they're diagnosed with their diabetes, they're on insulin. Not that strict regimen that we just talked about in type 1, where you're taking NPH and regular in the morning and NPH and regular at night. Maybe a little bit of NPH in the morning, along with the oral hypoglycemic agents. So a little bit different regimen. So you could control these patients on diet alone or have to use insulin later on in their course. He appears very lethargic. He's arousable but responds incoherently to questions. He only orients to his name and does not know where he is, and he does not recognize his wife. His temperature is 37.7, blood pressure is 100/60, his pulse is 110 per minute with orthostasis and respiratory rate of 20 per minute. His lung examination is normal with good air entry. His heart shows a normal rhythm with a murmur. There are no focal neurologic signs, and the rest of the physical examination is unremarkable. So now your differential diagnosis is about the same one that you think about in the first case that we talked about. You think about non-focal deficits, somebody presenting with altered mental status again, along with non-focal neurologic exam. So in this patient, what do we think about? Well, he had history of diabetes before, so definitely the first thing on our list here is non-ketotic hyperglycemia. And of course, we think about infectious process, we think about drugs, and the other things that we know in the mnemonic here when you have altered mental status and non-focal neurological exam. So we talked about metabolic causes, renal failure, and so forth. We talked about infection, especially people that are a little bit older will get infections and will present with altered mental status. Urosepsis is commonly seen in people that are 70, 80 years old to present with altered mental status. This guy is only 49 years of age. And of course, a CVA should be thought of only when the patient has focal neurologic deficits. This doesn't make sense here. We should focus here on electrolyte problems, infections, and drug toxicity. So our initial diagnostic plan sounds good here. A basic metabolic panel to look for electrolyte problems, a complete blood count to look for signs of infection, and a urine analysis to look for signs of infection, and along with that a chest x-ray to look for common infections like pneumonia. A lumbar puncture should be performed just like we did in the first case to rule out infections in the brain like meningitis, meningoencephalitis, and a toxicology screen. And if we go a little bit further down, we find that this patient has a pretty normal lab, except that when we look at his chemistry profile, we look at the sodium, it's 130. We look at the potassium now, it's 5.2. The chloride is 95 and the bicarbonate is 24. That's pretty much normal. If you do the anion gap in this patient, 130 minus the 95 plus 24, you realize that this patient has an anion gap of something like 11 or so. Around 10, this is normal. So a normal anion gap and the BUN creatinine 58 and 2.2 is definitely elevated. And now you look at the sugar and it's almost 1,000. So a normal anion gap, normal bicarbonate, sugars in almost in the thousands, in a history of patient with some kind of diabetes in the past, makes you diagnose immediately non-ketotic hyperosmolar hyperglycemia. So this patient has type 2 diabetes presenting with a complication of type 2 diabetes. This, by definition, is not like type 1. In this patient, we define type 2 diabetes as insulin resistance. So the most important thing in this patient, after you admit him again probably to intensive care unit, because these people are really sick, that's the first thing you do here, admission to intensive care unit. The second thing you do is give them what's the most important thing for these patients. It's not insulin. They have insulin on board. If you measure this patient's insulin, you may find it normal. You may even find it high. They have insulin resistance. So the most important thing in this case is giving the patient back the fluids. What's the type of fluid that we use? The same type that we use in all other patients, and this is 0.9 normal saline. Do we use a little bit of insulin? Yes, we can. No problem. Here you go. But this, it's not as important in this patient as it was in the type 1 diabetic, where we had to use insulin. Sometimes you'd be surprised, even with a glucose of 998, even with a glucose sometimes over 1,000, by giving the patient adequate fluids, you could get it back almost back to normal by itself and using only small amounts of insulin. The fourth thing here, just like we did in the prior patient, what did we look for? We looked for precipitating causes. This patient is not like our youngster in case 1. This patient is almost 50 years of age. So precipitating causes have to be a little bit more than just looking for infections. Yes, we look for infections, especially urosepsis and pneumonia, but we also look for, what do these people get? They get silent ischemia. So look for ischemia. This patient definitely needs an electrocardiogram at some point. So always look for precipitating causes in diabetes. Why did this patient present now with a hyperosmolar hyperglycemia? You look for these and you treat them analogously. So going back to the patient, this patient with just some fluids will usually get better. But if you compare this patient to the patient with diabetic ketoacidosis, if you compare hyperosmolar hyperglycemia, it's not only the insulin that's different. This patient has a higher mortality. This patient here, with the type 2 diabetic, has a higher mortality than the type 1 diabetic ketoacidosis. These patients are older individuals. They have comorbid conditions. This patient had hypertension. A lot of these people have ischemic heart disease. So they have a higher mortality and morbidity, even though type 2 diabetes is probably a better diabetes to have than type 1. So this is another big difference in these two complications of diabetes, that hyperosmolar hyperglycemia has a worse prognosis than diabetic ketoacidosis. These people are older with comorbid conditions. The type 1 diabetics presenting with diabetic ketoacidosis are younger individuals, and they could usually bring them out of diabetic ketoacidosis really quick. So the bottom line is high mortality in these patients. Look for it. Now, this patient, a couple of days down into the hospital course, 2-3 days later, if they don't have ischemia, if they don't have anything else, they usually do well. Most of them do. And you could discharge this patient home on low doses of insulin with a quick follow-up in your office. And your plan here is to get the patient off of insulin. Most of these patients, you don't do it right away, but within the first couple of weeks you could get them off the insulin, because we said most of them don't need it, and get them on oral hypoglycemic agents. The oral hypoglycemics that we like to use are two groups right now. Those are the ones that have been shown to make a big difference in these patients. One are the sulfonylureas. These drugs have been around 40 years now, the sulfonylureas. How do the sulfonylureas act? They act on the beta cells to secrete insulin. So they work on the beta cells to secrete insulin. Things like glipizide, glyburide, and so forth, they work on the beta cells to secrete large amounts of insulin. They're long-acting, most of them, so they work over 24 hours. So you only have to give them once a day, maybe twice a day at the most. They're great drugs. There's one, though, they particularly like to ask about, and this is called tolbutamide. Tolbutamide is the only sulfonylurea that is not metabolized by the kidney. So it's important, if you have a patient with renal insufficiency, you can't use the rest of the sulfa agents because they're metabolized by the kidney. So you're going to get toxicity, you're going to get hypoglycemia. The only one that you could use is tolbutamide. This gets metabolized almost 100% by the liver. Why people don't like to use it is because the short half-life. You have to dose it 3 times a day or 4 times a day, TID, QID. So nobody likes to use it. They only use it if they have to. So if you want to use an oral hypoglycemic agent in a patient with renal insufficiency, it's only tolbutamide. The other ones, you have to be careful. You could only use them with normal renal function. The second drug that has been around for now 5-6 years, but is the one that in studies probably has the best glycemic control in type 2 diabetics, is glucophage, or metformin. This is the drug they're going to ask you. Metformin. And this does not work on the beta cells. It works in a different way. It decreases neoglycogenesis by the liver. So your liver doesn't produce a lot of sugar. It decreases the amount of glucose that's absorbed from the GI tract. So your GI tract doesn't absorb a lot of sugar, and it probably facilitates glucose into the muscles. The most important mechanism is the inhibition of neoglycogenesis by the liver. That's the most important mechanism. So this is a great drug to use. There's different forms. You usually have to dose it once or twice a day, most of the time. There's an extended release form now that you could use once a day. But that's the drug to put the patient on. There's a problem with this drug that the most common complication is not lactic acidosis. It's not. The most common complication is diarrhea and GI problems. That's the most common one. If they ask you, what is the most common reason that you had to stop glucophage, metformin? It's not the lactic acidosis. The lactic acidosis is actually very rare. It is the diarrhea and the GI upset that it causes. That's the most common reason it's stopped. Now, in some patients, it does cause a rare complication that it's known for, and this is lactic acidosis. It is usually the patients that have renal insufficiency that this occurs in. It doesn't occur in normal patients, people with renal insufficiency. So you don't like to give it in people with renal insufficiency. You don't like to give it in patients with congestive heart failure for the same reason, because they may get renal insufficiency and so forth. It's a whole complicated issue. But the bottom line is, don't give. Don't give with renal failure and congestive heart failure. I'm just going to write renal failure because that's the most important one. So really, if you needed to use, again going back to what we were saying before, if you needed to use an oral hypoglycemic agent in type 2 diabetic, really the only thing that you could use is tobutamide if they have renal insufficiency. Okay? Very good. So remember those drugs here. Newer drugs like acarbose and some of the other ones that inhibit enzymes, gastrointestinal enzymes in the absorption of glucose, haven't been shown to make a difference. So if they ask you which drugs you're to use, these two drugs are the ones. You could use one of them, and if one of them is not enough, you add another one. In fact, there's combinations now of glucophage and sulfonylureas in the same pill. So you won't have to use two pills. Okay? So those are the drugs to use. Like I said before, the patient with type 2 diabetes, once they're diagnosed initially with type 2 diabetes, it may be that you can control this patient on diet. A little bit later, you may have a hard time doing that. So you may have to add some form of oral hypoglycemic agent. And years down the line, 10, 12 years down the line, you may even have to use insulin. Not in the strict fashion that we used it with type 1. When you talk to this patient, what are you going to tell them? What's the way to control their sugar? What should they have? What does control sugar mean? It means a fasting glucose less than 126, and this correlates with a glycosylated hemoglobin or hemoglobin A1C. Now remember, the glycosylated hemoglobin is a way to monitor sugar over 2, 3, 4 months. It gives you control. It gives you an idea of what the control is over the last 3, 4 months. And it correlates with a mean sugar depending on what the glycosylated hemoglobin is with a certain mean sugar. For example, I know if this patient has a glycosylated hemoglobin of 6.5 or less, I know that their mean sugar throughout the last 3, 4 months runs about 115 to 125. I know that very well. If their sugar, the glycosylated hemoglobin, runs around 8, I know that their sugar now runs in excess, most of the time, of 200. So it's not well controlled. In fact, it's probably around 250. So anyway, so this correlates with the mean sugar. These are not just random levels. Correlate with the sugar. So we want the fasting glucose of 126, and we definitely want a glycosylated hemoglobin less than 7, around 6.5. That's our goal. That's our goal. You can't diagnose diabetes with a glycosylated hemoglobin. Be careful about that. The diagnosis of diabetes is made through a fasting glucose 2 times over 126. You monitor the glycosylated hemoglobin, you monitor the patient's sugar over time. That's the way to follow the disease, but you can't diagnose it with that. Now, this patient, we should do one more thing. We have to worry about complications in this patient, right? Because in the type 2 diabetic, they occur from the time of diagnosis. In fact, when his doctor diagnosed him years back, they should have sent him to an ophthalmologist. They should have checked his urine for protein. So type 2 diabetes is not like type 1. When the patient comes to you and you diagnose type 2 diabetes, How long have they had the disease? Who knows? 5 years, 10 years, maybe even more. So when they come to you, at the minute they present, they may have the complications of diabetes already existing. That's not the case with type 1. You can't have type 1 for a long time. You can't live without insulin. These people have had it. That's why it's so difficult to study type 2 diabetics. You don't know when they've really had the problems with their sugar. Was it 5 years, 10 years? Who knows? The bottom line is they could present, the minute they present, they may have early complications of the disease. That's the most important thing. So right away, when you diagnose the patient with type 2 diabetes, the minute you diagnose them, you should look for complications. What are the complications? That you could reverse by good glycemic control. So those are the ones you got to look for. The retinopathy, only the microvascular complications we could reverse or stabilize by good glycemic control. And there's only 3. Retinopathy, right, the ophthalmopathy, nephropathy, and neuropathy. We can't control everything else. We can't control and we can't minimize by good glycemic control the peripheral vascular disease that diabetics get. We don't know if we could do anything about the coronary heart disease that they get. There's no evidence to support that. There's no evidence to support that we could do anything about the macrovascular complications associated with diabetes. We know very well from randomized studies that we could definitely control and stabilize with good glycemic controls the microvascular complications. In this country, the most common cause of blindness in middle-aged patients is diabetes, retinopathy, neovascularization. They get neovascularization, proliferative retinopathy. This, all of a sudden, the vessel busts, you get bleeding, and there's blindness. You could control that by good glycemic control and sending the patient immediately to the eye doctor, to the ophthalmologist. They will look at the retina, make sure there's no vascularization. If they find neovascularization, proliferative retinopathy, what do? They do laser treatments and photocoagulation so you don't get bleeding in there. The patient that has proteinuria with nephropathy, not only could we control their proteinuria with good glycemic control, but we know that we could put that patient on an ACE inhibitor to stop the proteinuria. So these are the 2 things you got to do right away. Check their protein in their urine, make sure they don't have microalbuminuria or macroalbuminuria. If they do, they need to be placed on an ACE inhibitor. You got to send them to the eye doctor to make sure they don't have retinopathy. It needs to get treated immediately. Going back to the nephropathy in patients with type 2 diabetes, all patients with hypertension and diabetes, like our friend here, the treatment of choice in these patients, the first line drug is an ACE inhibitor, always. This patient should not have been put on hydrochlorothiazide. 1, because it probably worsens glycemic control. Number 2, it doesn't do anything for the kidney. So first line in type 2 diabetics that have hypertension, first line is an ACE inhibitor. If the patient has no hypertension but has proteinuria, then that patient also needs to be put on an ACE inhibitor. So which patients that are diabetics do we treat with ACE inhibitors? The patients that have proteinuria and or the patients that have hypertension. The other people that don't have hypertension and proteinuria, we probably don't right now. Maybe in the next couple of years, you're going to find out about some studies that are going on, and maybe we need to treat those patients too. But right now for you, they have to have one of those 2 or both, hypertension or proteinuria. Okay? Very good. The neuropathy may present in one of 3 ways. I just want to go into that and make sure you understand that and then go into the next case. But it may present in one of 3 scenarios. There's 3 types of neuropathies that we see. We see the classic stocking and glove neuropathy. They get pain, distal pain, pins and needles. Very nasty. Then there's a mononeuropathy that could happen. They get a foot drop or a wrist drop, mononeuropathy, one nerve. Or if it involves the cranial nerves, it's usually cranial nerve 3 that's involved. So mononeuropathy. And then there's this thing called the autonomic neuropathy, where every time they tell you they eat something, they get bloated, right? And they have diarrhea, and it alternates with constipation. So what is this called? Gastroparesis. They sometimes may have erectile dysfunction and impotence, and so forth. They may have orthostatic hypotension. These are form of autonomic neuropathy. So if they ask you in any of these 3 syndromes that we just talked about, can you reverse these syndromes? Well, you could at least stop them with good glycemic control, because this is all part of the microvascular complications of diabetes. So that's the bottom line there. Good. So I'm going to leave our third case and go a little bit further down. So this patient was sent home and went to oral hypoglycemics and did very well eventually. And I'm going to leave this case and go a little bit further down onto case number 4, where we have a 30-year-old guy that comes into your office for routine medical evaluation. He denies any specific complaints right now, so he doesn't have anything going on with him, not taking any medications, but his past medical history is significant for several episodes of renal stones 2-3 years ago, so this is important, and his physical examination is unremarkable. Now, he was sent to you because they had found in a routine exam before that he had a serum calcium that was elevated. So a 30-year-old guy with no symptoms whatsoever, except that he's had kidney stones before, that you find incidentally a hypercalcemia. Well, you want to make sure they did the right thing here and there wasn't a lab error, so you'll repeat that, and of course, again, you'll find that his calcium is increased and he's to 11.3, so that's significantly elevated. So the question is, what causes hypercalcemia? Well, the first couple of things that should go into your mind is the most common one. So the most common one, which is primary hyperparathyroidism. That's the most common one. And this is the most benign, too, out of some of the other ones that we're going to talk about. So this occurs most of the time because there's a single adenoma in the parathyroid glands. It's autonomous, so it has no feedback. It's autonomous, and it secretes parathyroid hormone. A single adenoma about 75% of the time. In about 15%, 20% maybe, it's four-gland hyperplasia. That's an interesting disease because four-gland hyperplasia, well, what are you going to do about that? And the patient has significant hypercalcemia. Well, you got to take all of them out and then kind of put one in the forearm where there's good vasculature here, and the surgeon has access to that. So, you kind of chop a little bit off until the calcium goes down to normal. That's what they usually do. So 75% or so of the time, it's a single adenoma, and then about 20% of the time, it's four-gland hyperplasia. The rest of the time, it's rare diseases like parathyroid cancer and so forth, things that we hardly ever see. So this is also, I said, the most benign form, and it is also the most common cause of hypercalcemia. If you take all patients all around with hypercalcemia, you'll find that primary hyperparathyroidism is the most common one of all. 50% of the time, it has no symptoms, just like our friend here. They notice no symptoms. So it's a mild form, mild elevation of calcium. What does hypercalcemia do when it causes symptoms? Well, it causes kidney stones, right? It causes bony pain, right? It causes belly pain because of some of the stuff that we're going to talk about. So this patient, the only symptoms that he really had is maybe the renal stones. Maybe they were related to hyperparathyroidism. They were likely related to that. So maybe he's not totally asymptomatic. Well, if you secrete parathyroid hormones, continue to secrete it, you activate the osteoclasts. The osteoclasts break down bone, release calcium in the serum. The calcium should go back and have a negative feedback and stop the parathyroid hormone. It doesn't. This is an autonomous adenoma. So it continues to do that. So eventually, why do these people develop bony pain? Well, after years or maybe months of activating the osteoclasts, you get bone breakdown. In fact, you get these cystic spaces in the bone of bone depletion because the calcium is all released into the periphery. And this has a name. Sometimes they're called brown tumors, or this disease is called fibrosa cystica. So you find these cystic spaces in the bone. That's why the patient has bone pain. So that's one thing. They also cause, because of hypercalcemia, calcium stones. So that's the kidney. That's the most common way this patient presents, but I said 50% of them are asymptomatic. Now, the definitive treatment for this is surgery. This is the definitive treatment. Do you have to treat the patient with surgery all the time? The answer is, if the patient has symptoms, yes, you do. If the patient is older and has mild hypercalcemia, asymptomatic, no renal stones, then you may just watch the patient. But if the patient has symptoms, especially if the patient is a young person, well, their bones are not going to do that well 20 years down the line, so you probably should treat it. What they usually do before the surgery is get an MRI of the neck, the parathyroid glands. They localize it. They want to know. The surgeon wants to know, am I dealing with 4-gland hyperplasia? Am I dealing with 1 gland? Wants to know. So they visualize it with the MRI. Then they go in and they take it out. Now sometimes, this is what happens. This is a patient with primary hyperparathyroidism. Look at that. These are the 4 parathyroid glands. This is the one that is secreting autonomous parathyroid hormone. This works on the bone, right? Here's the bone, activates the osteoclasts here, kind of like this, to release calcium. There you go. So calcium is elevated, and we said most of the time it's 1-gland hyperplasia. Right, so 75-80% of the times, this is what they're looking at. This goes back to high calcium here and kind of tells the rest of the parathyroid glands to stop working. They don't need to be working, right, because now you got a negative feedback here. Well, it also goes to this guy here, but that's autonomous. That's the nature of the problem here, is that this is an autonomous adenoma. So these glands, these 3 glands here, are suppressed. They're suppressed for a long time. Okay? And now you have the surgeon that comes in, and what he does, or she does, is resect this. Right? Resect that. They take it out. Well, now look at this. Remember, parathyroid hormone is the main hormone that adjusts calcium in your blood. If you don't have parathyroid hormone, you get tetany. Your calcium goes dropping down. Well, look what happened to this guy. We took out the major source of parathyroid hormone. You get these bones here that are depleted, right? They got these cystic spaces. Here's the fibrosa cystica, depleted bones of calcium. You got 3 pretty non-functional parathyroid glands. So what happens now? All the calcium in the blood, without anything to hold it in the blood, there's really no mechanism now, since these 3 are not working, goes and deposits onto the bones. So this is called the hungry bone syndrome. Hungry bone syndrome occurs because of two issues. One, because the three glands are suppressed. The rest of the glands are suppressed. Number two is because you got bones, hungry bones, depleted of calcium. So this patient goes from a state of hypercalcemia to a state of hypocalcemia, and this patient, you'll go by the bedside 12 hours later after the surgery, and you'll notice that all of a sudden he starts winking at you, right? And you start to tap over the facial nerve. And what happens? Right? You notice that this patient has latent tetany. Cross-deck sign and trousseau sign, you put the cuff on and you inflate it for a minute and they develop tetany. So after you do surgery in people with primary hyperparathyroidism, it is important to monitor these patients' calcium. Put them usually on a monitored bed and watch the calcium closely for the development of hypocalcemia. Very important. Okay? These people, once their calcium starts to drop, what's the answer to this? You got to give them IV calcium gluconate. So this is important. So that's primary hyperparathyroidism. This is the most common cause of hypercalcemia. And given that this patient only has kidney stones for a long time, this is what the likely cause is. But in our mind always comes the second cause, important cause of hypercalcemia, and this is cancer. Now, we said this is the most important and the most common cause right here. If you take hospitalized patients with hypercalcemia, now they were admitted to the hospital because of hypercalcemia, you'll notice that if you look at the diagnosis in these patients, by far now the most common one that does that is cancer. So we're looking at different populations. If you're looking at outpatients with hypercalcemia that didn't have any symptoms or had mild symptoms, by far this is the most common cause. If you're looking at patients that had to be hospitalized because of malignant hypercalcemia, you don't just hospitalize anybody with hypercalcemia, it has to be bad hypercalcemia, then the most common cause is cancer. So really cancer causes a severe form of hypercalcemia with a lot of symptoms. Sometimes the patient have to be hospitalized and treated. We'll talk about that. There's two ways that cancers do this. One is through metastatic disease. Mets to the bones. That's one way. The classic scenario is multiple myeloma. So you could have breast cancer with metastatic disease to the bone. You could have anything. It's usually lytic lesions, though. They activate osteoclasts through tumor necrosis factor, some interleukins, leukotrienes, and so forth. But it is a focal effect. It is a focal effect. It's usually diseases that metastasize to bone. If multiple myeloma does not metastasize to bone, there's no chance of hypercalcemia. That's really the bottom line. So through metastatic disease to bone. The second way that is very important that we talked about when we talked about cancer-related issues is through a parathyroid hormone-like molecule. And this occurs in squamous cell cancer. Now, squamous cell cancer occurs in the lung, and it also occurs in the esophagus. It's more common that we see it in the lung because it's a more common cancer there. So this parathyroid hormone-like molecule acts just like the parathyroid hormone that your parathyroid glands secrete. It activates the osteoclast, but it's very aggressive now. Squamous cell cancers rarely metastasize. They have focal growth. So how could a cancer do it with just focal growth? Well, this is why. It secretes a parathyroid hormone-like molecule. This molecule is parathyroid hormone-like. It's not exactly the same as parathyroid hormone endogenous production by the parathyroid glands. This is important because the way you decipher between the two is what? Is you measure parathyroid hormone. Our assay for parathyroid hormone is very specific. It's expensive, but very specific. So when the parathyroid hormone assay that you do is elevated, this can only come from the parathyroid glands. And if you find hypercalcemia with an elevated parathyroid hormone level, this could only be from the parathyroid glands for your purposes. So this you've diagnosed primary hyperparathyroidism. If, on the other hand, you check the parathyroid hormone and the PTH now is low, well, there's a lot of disease it could be, but you definitely think about cancer. There's a specific assay where you could check for this parathyroid hormone-like molecule. And if you're thinking about cancer, maybe you should do it here and check it. Check a parathyroid hormone-like molecule. The point that I'm trying to make here, the clinical point, is what? That when you measure, when you get the normal assay for PTH, it could only be elevated with endogenous production from the parathyroid glands. This PTH-like molecule does not get picked up by the assay. So maybe here, this patient had cancer. Maybe. The treatment of hypercalcemia, when it is severe, is the same throughout. It is most commonly severe in cancer-related issues because this is malignant. What's the treatment? Well, think about it. We got to get that calcium down. We got to get the calcium down. So these people have dehydration, severe dehydration. So the first thing, the most important thing in treating severe hypercalcemia is giving the patient fluids. That's the most important thing. Initially, this is the most important thing, giving the patient IV fluids. Always 0.9 normal saline. How much fluids do you give? You give 1 liter, and another liter, and another liter, and another liter. The second thing is, if you got cancer, once you stop the fluids, hypercalcemia will occur again, most likely, because this is usually in the face of metastatic disease. Most cancers cause hypercalcemia in the late stages. It's not early that they do. Squamous cell may do it sometimes, but most of them are metastatic end stage. So maybe you need to treat the patient with a more permanent treatment. And here comes calcitonin and pamidronate. Now both of these are used in osteoporosis. Same things. We use a shorter acting pamidronate. It's called alendronate, Fosamax. So these take calcium and deposit onto the bone. They do that in osteoporosis because people with osteoporosis are missing calcium. So we want that. Here, we got high levels of calcium in the serum, and we want that also. We want to deposit onto the bone. The bone, it's okay. In the serum, it's bad. Calcitonin has immediate action. Action within the first 24 hours. So you get immediate action. After 24 to 48 hours, the action of calcitonin weans off, goes away. You get this thing called tachyphylaxis where the body kind of gets used to it. So it doesn't have an effect after 24 to 48 hours. Pamidronate, on the other hand, the action is after 48 hours, but it's sustained. It's sustained 2 weeks. So if you combine these together, in usually the severe patients with hypercalcemia, you will get an effect immediately with calcitonin and then get a more sustained effect about 24 to 48 hours later because you have given the pamidronate along with that. So that's usually the basics of treating hypercalcemia. Most patients with hypercalcemia, no matter what the cause is, despite being cancer most of the time because of the severe symptoms, have to get treated this way. You will hear about some other treatments like mithromycin. These are usually drugs that have to be given in severe hypercalcemia that is resistant to calcitonin, resistant to pamidronate, and usually is given in cancer-related, again, issues. One thing that we get into trouble and we forget here in this whole protocol is this. If you look at the treatment of hypercalcemia, you'll see that along with all the stuff, furosemide is given, Lasix. Furosemide is given not so much to decrease the calcium. It has a very mild calciuritic effect. So it's not a great drug to decrease calcium. The reason why we give it in this whole scheme of things is because the main treatment of severe hypercalcemia is what? IV fluids. So you give the patient fluids and fluids and fluids. These are cancer patients, so they're kind of older. So what do you think happens to them? They get fluid overload. So when the patient gets symptoms and signs of fluid overload, then and only then do we give IV furosemide. Now this is very important because if you give furosemide early on, you give it initially, you write down the orders for the patient, give the patient 0.9 normal saline wide open. Give the patient also 60 milligrams or IV furosemide, Lasix. The patient will get the furosemide first. The nurse will go and give them the furosemide, and even if they get it second, it still will have an effect on the patient initially. It will cause diuresis. It will cause worsening of the dehydration. So the calcium, instead of going down, if you give them the furosemide initially, the calcium will likely go up. So be careful about this. Most people think it does something to the calcium. It doesn't. It shouldn't be used unless you have evidence of fluid overload. So, going back to our initial diagnosis, the first two things we were thinking of primary hyperparathyroidism versus cancer. That's our first two thoughts. So the first thing we always get is a parathyroid hormone level. Having said that, there are some other things that we need to think about, some other diseases. Sarcoidosis, we talked about before in the pulmonary section, causes hypercalcemia. How does it do it? Through hypervitaminosis deactivation through the macrophages. In sarcoid-induced hypercalcemia, what's the treatment? Well, if the patient has symptoms, you got to give them this. But how do we treat hypercalcemia? In sarcoidosis, you have to give the patient steroids. Not in other diseases, in sarcoidosis. So don't put this down here as a form of treatment of hypercalcemia with every disease. This only should occur in the face of sarcoidosis. There are two diseases also that they're common enough for the boards to ask you that you usually don't have to do anything in terms of the hypercalcemia. One of them is called hypercalcemia associated with immobility. This usually occurs in patients that are long-term facility patients, don't move around a lot, usually patients with stroke syndromes, in bed all the time, and there's a mild hypercalcemia that occurs with these patients. You don't have to do anything about that except watch it. Okay, so if they ask you what is the likely cause in a bedridden patient of the hypercalcemia, you tell them it's this hypercalcemia associated with immobility. Another form of benign hypercalcemia is the syndrome called hypofamilial hypocalciuric, hypercalcemia. Well, think about the words here. Well, they got hypercalcemia, right? And it runs in families because it's called familial, and it's because they can't excrete or secrete or get rid of enough calcium. So their urine has low calcium. They hold on to too much calcium. There's something wrong with their mechanisms in their tubules. They don't get rid of enough calcium. These people have no symptoms. No symptoms at all. None whatsoever. So if you're talking about somebody like that, it runs in the family, nothing happens to them. You're talking about this disease called familial hypocalciuric hypercalcemia. Has no symptoms for your purpose. Sometimes on the boards they like to trick you a little bit, and they like to tell you that one of their relatives who had hypercalcemia, the father for example, was sent to the surgeons, and had their parathyroid glands removed 20, 30 years ago. But their calcium level still remained high. 20, 30 years ago, we couldn't measure parathyroid hormone levels. It was very difficult to do. So you virtually, patients with hypercalcemia, you would send them to the surgeon. And the surgeon would go in and explore and take out a couple of the parathyroid glands to see if they got better. Because primary hyperparathyroidism, it was the most common cause. Still is. Well, these patients, though, never improved because it wasn't about the parathyroid glands. It was about this renal excretion of calcium. Okay? So, two benign causes, hypercalcemia associated with immobility and familial hypocalciuric hypercalcemia. Both of these have no symptoms. You just watch the patient and don't worry about it. Okay? So, let's go back to this patient. They found that the calcium was normal. The chest x-ray and everything else was normal. And they did an immunoassay of the serum parathyroid hormone. This is elevated. It is elevated. So what did you just diagnose? Primary hyperparathyroidism. What is the next step to do in this patient? The definitive thing to do is surgery, because this patient has had kidney stones. This is symptomatic primary hyperparathyroidism. 1 week later, the patient is admitted to the hospital and has successful removal of a single parathyroid adenoma. That's what you expected. He's doing well after surgery and he's transferred to the surgical wards. The nurse contacts you 12 hours after the surgery and tells you that the patient has developed facial spasm. What do you expect now? You expect that this is the hungry bone syndrome. The patient needs to be on IV calcium. You should have suspected that beforehand. Okay? Very good. So that's the case of hypercalcemia. I want to go down a little bit further down onto case number 5. And here we have a patient that feels tired all the time, a 64-year-old woman who complains of feeling tired all the time for the past 6 months. She was planning to visit you, her primary care physician, for a while, but put it off until now. She has gained about 8 pounds in the last 6 months. She does not feel like doing much of anything. She complains of feeling cold and has been using heavy blankets even in the summer. So it's not only feeling tired, but now she has this problem of feeling cold all the time. She's constipated, gets frequent headaches, and experiences severe muscle cramps. The only good thing is she has to report was that her anginal chest pains are not as frequent as they were before. She only had 2 episodes of the chest pains in the last 6 months or 4 months or so. For her angina, she was taking isosorbide and a beta blocker. Her cardiologist recommended coronary artery bypass graft for cardiac catheterization, showing a 70% obstruction in the left main. Her blood pressure is 150/100. Her pulse is 50. Her skin is dry. There is no thyromegaly. The deep tendon reflexes have a delayed relaxation phase. The rest of the physical exam is unremarkable. I will tell you one more thing. If you ever got her cholesterol, even though she probably had a normal cholesterol before, the cholesterol starts to elevate. Why does this person, what does this patient have? Well, if you put deep tendon reflexes that are decreased in the relaxation phase, you put a patient that feels fatigue all the time, you put a patient that has constipation, her angina went away all of a sudden, well, you think about primary hypothyroidism. It's the most common form of hypothyroidism. And the disease that does it more commonly than anything else is Hashimoto's thyroiditis. Hashimoto's thyroiditis is a chronic form of thyroid inflammation. So it occurs over long periods of time. And after inflammation of the thyroid for a long period, there's scarring and fibrosis. So eventually, these people develop hypothyroidism. Well, what do? The best screening test for this is to check a TSH. And then if that's abnormal, then to check a free T4. So if it's primary hypothyroidism, the TSH should be elevated. And the free T4 should be low. Please let me tell you, you will get a couple of problems with thyroid hormones. Remember that it's only the free T4 that we look at. That's the one that is metabolically active. If you look at total thyroid hormones, here it is. This is total T4. You will notice that only 0.01% is free. This is the one that's free. 0.01%. But this is the one that is active. So that's the one you look for. This is the one that has the feedback back to TSH and even higher to the hypothalamus. So you only look at the free T4. The TSH is a very important test. If the TSH is normal in a patient that you suspect has some thyroid problem, if it's normal, the patient has no thyroid problem. I'm telling you right now. If the TSH is normal and you suspect a thyroid problem, then it's not a thyroid problem. So that's the first thing you look at. That's the first thing. If that's normal, pick normal thyroid function, pick euthyroid. Now in this patient, we find that the TSH is high, the T4, free T4 is low. We've diagnosed primary hypothyroidism. What do we do here? How do we treat the patient? We give the patient back thyroid medication. What's the problem with this patient? She's older and she has coronary heart disease. If you give back the patient thyroid medication, you have to start slow. You start with 12.5 micrograms, you go to 25 micrograms, you go maybe to 50 micrograms, and maybe later, after about a couple weeks or so, maybe to about 100 micrograms. It's about 100 micrograms that usually stabilize the patient, and after that, you go up and down on it, trying to get it back to normal. Okay? This patient, though, we don't do that. She has coronary heart disease. If you put her back on thyroid medication, she will develop angina. So you rather proceed into bypass surgery or stent surgery first, and then replete, give back the thyroid medication later after the coronary bypass surgery. There's good studies to support that these patients do just as well when they have mild hypothyroidism, when they're taken to surgery, as the patients who don't. So the bottom line is, this patient will go to surgery first, then we'll give back the thyroid medication. So I'm going to stop right there, and We'll take a small break and come back and continue with the endocrine part.